we're basically going to go through what sort of an ideal case looks like for minimally invasive surgery, minimally invasive spine surgery. So anyways, so getting going here. The things that we're going to talk about are the disc space, flexibility, sagittal coronal profiles, the surgeon profile, and then some other topics if we can span and get to there. So we talk about the principles of ideal minimally invasive surgery. You have to remember that just because it's done with a less invasive approach doesn't mean you get to skip all the other stuff. In other words, we want to make sure that patients have DEXA scans that are in the right parameters. If they're less than minus 2.5, then obviously we need to have them treated preoperatively. If their hemoglobin A1Cs are low, making sure that they're non-smokers, and if they are smoking, that they quit and have serum creatinine levels that are appropriate. Total lymphocytes counts have to be over 2,000. Their MEDs have to be less than 50 and the BMI less than 35. So those are sort of the parameters that we have in place right now at Scripps to get patients qualified for these operations. And pretty important because we're checking this on everyone that's having these operations to make sure that they get through it safely. So one of the main principles in MIS surgery is that the anterior column is really your workhorse, and we are achieving our fusion through there, but we're also achieving a lot of our correction through the anterior column, and we're using the disc space predominantly as that workhorse. And I don't know if this is going to play. All right. Well, that video shows like a 5-level anterior with a fusion looking pretty good on these. But the concept here is that you're using your fusion using the anterior column to get your fusion. What that means is posteriorly, it kind of takes the pressure off a little bit. You don't have to skeletonize all the bone and then decorticate it, fuse it, because the disc space anteriorly is going to be fused ahead of time. Same thing, the correction workhorse is also coming from anterior. So patients that have sagittal or coronal malalignment, we're using the anterior column for corrective purposes. And what that would look like here briefly, and I think I go through this case in a little more detail a little bit later, is just that you're using the disc spaces available to you to get the desired correction that you need. And this is showing that same patient in between stages. You can see that here we achieved a very nice correction through the anterior column, and the numbers aren't quite popping up here, but you can at least see that the lordosis distribution now looks pretty darn good in the scout film on the CT scan relative to where they were preoperatively. A couple things to note when you're looking at this, which is that the disc spaces, if they have a bunch of air in them, we really like that. It's a good sign that there's some flexibility. The air pops up because there's motion at that level. So when we see here, we're typically pretty happy about that because we can use that to our advantage. We also have to understand if they've had previous surgery. You have to evaluate for any ankylosis posteriorly. And always watch the facet joints. The facet joints are important not only from the ability to assess their flexibility, but also patients that end up having stenosis. Sometimes you'll need to do an actual decompression if the facet joints are overgrown within the canal, but we'll leave that for a talk later on. I guess is just showing again the CT scan with the correction in place, and you can see how her PI was 62 preoperatively, and then if you look over on the right side, the lordosis is now at 57 degrees, and that's without touching the posterior column at all. Also, you want to assess the flexibility. So rigid deformities aren't awesome for MIS. Sometimes we'll push the limit on that, but we typically like to know that there's some flexibility, because if there is, we can use that flexibility to our advantage. And that includes both regional flexibility, global flexibility, what they look like in the operating room. And then also understanding that each patient's different and we have to evaluate them independently. And that includes not only radiographic, but also just taking them in the office and laying them down and doing a really good physical exam to see what their flexibility is, just even in the office. Here's just a couple examples of that. His patient standing to supine. You can see that the disc spaces definitely have some air in them on the right side. On the left side, you don't see it quite as well. And that just shows you that he does have flexibility. And here again, in the standing versus supine position, see some passive correction that just happens by changing in posture. Always conscientious of the coronal alignment in these patients. I remember when you're doing things through a less invasive approach, it's a little harder to make smaller adjustments. And so patients that have these curves that we call a type C curve, so that the thing that becomes really important on these C curves is the fractional curve, and that would be the curve that exists usually between L4, sometimes L3, and the sacrum. And when that curve is substantial or rigid, then you'll usually be able to correct the lumbar curve, the main curve, pretty well. But if that fractional curve doesn't correct in response to that, then the type C curves will be way more imbalanced than they were to begin with. So you just have to be cognizant and conscientious about what you're doing to that. So when I typically think about these cases, I want to think about which levels have to be included for the fusion, and that'll be the minimum amount of what you do. And so a lot of times that involves like, all right, I typically will need to treat cob to cob, and that just makes sense from a standpoint of fixing the curve if that's what you're after. And then you have to take some principles of balancing that correction, which sometimes means level selection of your UIV could end up being a little bit higher just to balance things out. And finally, you definitely want to apply some of the degenerative principles that we know of ahead of time, which means looking at the facet joints and the disc spaces. And if they're very diseased disc spaces or facet joints, oftentimes those will be included in the fusion. So it's a little bit different than in the kids, where we definitely try to keep the levels much more succinct, because we're not dealing with, potential adjacent segment issues, et cetera. One thing I didn't include in the slide is that for the UIV, is we also are starting to look at the Hounsfield units at the upper instrumented vertebrae, and that a lot of time will influence whether I go, up a level or not. If the Hounsfield units are substantially better on the CT scan, then that can potentially make a strong argument to end at a level higher, just because the fixation is going to be better. So how do you get coronal realignment? Well, it's usually multi-level laterals. I actually end up using slightly smaller cages in these instances because I really want to leave myself a little bit of wiggle room when I go posteriorly to allow for some of the correction that we see. And then the fractional curve is critical in these. You got to really evaluate that bottom, and you got to work really hard to get that fractional curve corrected. Even from anterior, you'll hear us talking about in conference how we evaluate the sacral obliquity, and then we use that data to determine how we end up putting the actual interbody implant into the patient. So like if you take this patient here that you see here, the left is on the left and right is on the right. But on this patient, you may want to put the ALIF implant in such a way that allows you put it in asymmetrically at an angle, so that when the patient stands up, or when you're doing the correction posteriorly at least, the vector of correction is in line with how you need to fix the fractional curve. This is a really important paper that if you guys haven't read, I really want you to. It's a very simple classification of how to look at coronal deformity. It basically just walks you through three kind of curve types. It just simplifies it really, and I believe is really helpful, especially in MIS surgery. So the type A's have the curve. Our patients where they have a curve, but their coronal is spot on. The type B's are when the patients are leaning towards the side of the concave part of the curve. And then the type C's are where they're leaning away from the concave part of the curve. And this just goes back to the concept I was talking about earlier, where if you, for instance, the patient on the right, if you fix that main curve and you don't fix the fractional curve, you can see how they'll be listed way to the right instead of being balanced afterwards. So here's a patient that has a type A curve. It's balanced. We do a couple interbodies and get the fixation in and keep them as a type A curve. Here's another type A curve. You can see that the deformity is a lot bigger. But on this one, done all MIS, you can see that I have her imbalanced afterwards, right? I did two things wrong here. One is I didn't fix the fractional curve well, so now she's leaning all the way off to the left. And then secondly, we over-lordosed her, and now she's got PJK and had a kyphoplasty and et cetera. But this is not what we want to do. This is overcorrection in both planes. Here's a type B curve, patient leaning towards the convexity. We really like these for MIS because these patients don't usually have too big of a fractional curve, and you can usually correct that main curve pretty easily with the lateral interbodies because it's going to force everything back to the left in this case. So you're using the corrective power of ligament ataxis, and is a very again a nice setup for MIS surgery. The type Cs are tricky. A lot of times with type Cs, we end up not, well, I do at least. These are the ones that I will more frequently go open on because I feel like that fractional curve needs to be fixed. And so this is a lot of times a game time decision based on how well you do with your anterior work, usually between S1 and S1. But this is what she looks like after surgery. You see your type C curve. Had pretty good balance to begin with sagittally, and kept her there. On her, though, we did use laterals as well. I would say nowadays I probably don't use laterals much anymore for this curve because we can make it flexible posteriorly. And then here she is, Brita post after. Here's a 50-year-old female that had an adult idiopathic curve, and you can see how she had also a bit more of a type C. However, her curve location, when you look at her fractional curve, was not severe at all. So she was leaning more because of the thoracolumbar curve. On her, because the fractional curve wasn't a huge deal, this is a great candidate again for MIS work. Here's a patient that kind of exemplifies that sagittal plane deformity in addition to the coronal. It wasn't terrible pre-op, but you can see with some anterior work and rebalancing, we got her to be nice and level. So this one I was saying, like based on her Russell type, her apex of her lordosis needed to be right around L4, L3, with L3-4 disc. So this one was nicely recreated because we matched her needs. So again, it just one of these where you have to be pretty particular about where you need to get the lordosis. She's also 79, so we didn't want to do something huge on her. So this ended up, well, it ended up being it's a big operation, but being able to do it through the less invasive techniques makes this much more palatable for this age group. When you need more, we do things like ECRs, which is cutting the anterior column as well, anterior longitudinal ligament to really get a ton of lordosis out of it. Again, we'll talk about a lot of the principles as they surround this type of patient throughout the year, but just recognize you want to create an apex like this relative to what their spine demands, especially as it relates to the Russell type of spine that they have. Sometimes you need more. This is a patient that we ended up doing minimally invasive PSO on in addition to an ACR because he had such a big deformity. You can see a pretty nice radiographic result at the end. So the screws end up being the rebar. So if your anterior column is the workhorse for correction and for fusion, then think of the screws as what's going to provide the stability while the fusion is taking place. So if you do this part well, then obviously patients are corrected very nicely. If you do it incorrectly, you can either hyperlordose patients or probably more commonly what we see in the community is some flattening the lumbar spine as a result. The laterals will make the spine flexible, and so how you position the patient on the table really does matter, and you have to pay attention to it. And it's not something just to pay attention to at the very beginning of the case. This is something you have to keep reassessing, in particular when you get ready to place the rods, because the spine will relax and change over time in the operating room. So our obligation really is to provide a great bony, great environment for bony fusion or bony union. So like my mantra is, yeah, I always do the right thing. And so I don't get so caught up in the type of procedure. Just know that if you don't feel like you're going to achieve a good fusion, then you have an obligation to that patient to do whatever you need to do to get that done. So I always believe in general in the lumbar spine that any of these flexible discs really should have an inner body in place prior to minimally invasive posterior techniques. So that provides stability, provides a load sharing environment, and certainly a much better fusion surface area. Again, the fusion is the workhorse for fusion correction and using the disc space. Just a case example here to finish up and then open up for some questions. It's a gentleman, again, with a pretty standard adult degenerative scoliosis. You can see his numbers there on the right. Has mild mismatch at about 10 degrees for his lordosis. Otherwise, he's very well compensated as his pelvic tilt is 18, SVA is 3, and then has a type B curve because he's off to the concavity of his scoliosis. Here's his imaging on MRI, and unfortunately, it's supposed to be a video, but he has foraminal stenosis with no real central stenosis to speak of. Here's his scans showing a lot of air in the disc spaces anteriorly. You can see where the majority of this curve is happening really in the mid-lumbar spine with a relatively small fractional curve. So on him, we did a 2-level anterior, did a 3-level lateral, and then did the remainder of the correction posteriorly. Even here, you can see lordosis generation is pretty darn good, and something that we'll assess in the operating room. Coronally, we hadn't touched on this yet, but we use this thing called a T-square, which is a 90-degree line that allows you to understand how balanced or imbalanced your patient is. And then you can use compression distraction techniques to make adjustments as needed for realigning patients. And so this will help you quite well to figure out if your correction is leaving the patient in a balanced posture or not. And then your post-op results look something like this, and here it is period of post. So that's what I got for this morning. Sorry we had to pivot here last minute, but hopefully that was beneficial, kicking the year off. And we'll open up for any questions.
Hey, Greg, I've got a question.
Yeah.
Yeah, so clearly with that case, you're showing all those screws being put in perk after the inner body, so there's way less posterior muscle stripping, and so you'd obviously be, looking at that as one of the advantages of doing this MIS instead of open. Are you anecdotally or otherwise seeing these patients leave the hospital earlier or get up out of bed earlier or anything to that extent, decrease their length of stay? Post-op narcotic requirements, et cetera. Are you seeing anything different compared to doing that case open?
I don't think so, Rue. I think if anything, sometimes doing 3 different surgeries ends up being a little bit more invasive in some ways. You're doing 3 separate approaches. I certainly, we used to stage these all the time, and I know Bob and I for sure are gone very much away from staging anymore, because we feel like patients, it's not fair to patients, and the benefits that we used to want to stage them for is understanding their neurologic symptoms or their recovery. That's no longer the big issue anymore, because we're pretty comfortable with indirect decompression and things like that. So I would say the early perioperative period is not easier. you know, especially if you're putting 3 holes in the psoas, like walking's a little more challenging and for different reasons. So I think the first 2 weeks aren't. I think where you really see the difference is like that 6 week to 3 month interval, where they kind of tend to bounce back a little quicker at that point. But I think the early perioperative period is equally as intense.
I would agree with that. And I'm not so sure the perk screws over that many levels isn't pretty painful. And I think there's a difference between doing that and in the open technique. In some sense, you denervate all those structures when you do an open and kind of pillage the landscape, but you probably take away some of the innervation of those same muscles, you know? So I almost have a sense that the perk screws, because you leave all that innervation in place over that many levels, can be actually a little painful over the open.
That's an interesting thought, Bob.
Yeah. We should do RFA on all of them.
Yeah. But essentially you're doing that on an open, right? You're
right. Yeah. Very true.
Hey, Greg, can I ask a quick question? When you're doing all these screws perk, are you making any attempt to do like a facet fusion, or are you primarily just relying on the interspace?
Use the facet joint for correction. So if I feel like one level is arthritic enough, or I need more correction out of it, then I'll 100% lop those facets out. When it comes to fusion and knock on whatever, I am not an aggressive decorticator and fuser of the facet joints in areas that have an inner body. So in those, I will very commonly not do a formal fusion posterior. But if I take them up, say a couple of those cases went up to T10, the facet joints between like T10, 11, 11, 12, and 12, 1, they need to be decorticated. So those are the ones that end up getting a formal fusion. And I actually take the facet joint out and make a little box like that, and then burr out the cartilage. And then I actually I'll usually get like a small BMP and then cut it up into like 6. And then I'll use 3 on one side, 3 on the other, and pack bone graft on top of it. So I use a little bit of BMP and some allograft of some sort, or DBM.
Makes sense.
I agree with that. And just to reiterate his point, releasing the facets is I think can be pretty important if you want to tweak things. When you have those inner bodies, you don't have a lot of flexibility to move the spine, and rather than demanding a lot on the screws, which are polyaxial, you don't have really close mechanical capacity to move the screws. You have to make the spine a little more supple if you want to reduce things or compress or distract a little bit here or there. So that's the main reason I'll do it, is just to adjust on a subtle basis, but you don't have much capacity to do that without doing a little bit of release through the facets.
Awesome. Well, guys, it's 7:05. I know some of us need to get rolling. So